Thank you for that flattering introduction. It's an honor to be invited to speak to you here about neuropathies, which I've been working on, seems like yesterday, but it's been about 40 years. But it's a very broad topic, so obviously a lecture has to be somewhat superficial to provide an overview, hopefully demystify the topic of neuropathy, and people might have more specific questions after the talk. So when we talk about neuropathy, it's a general term used to describe any condition which affects the peripheral nerves. In England, they use neuropathy to describe ailments of both the central and peripheral nervous system, but here in the States, it's used to describe specifically peripheral nervous system ailments. And this disclosure, some conflict of interest, paid consultant, research support, book royalties. But I always tell younger students that the only way to avoid conflicts is not to get out of bed in the morning, so that's okay as long as they're declared. So this is just a diagram of the peripheral nerves. The nerves are really like wires which convey electrical impulses to the muscles and skin. They cover the body as an electrical network and control many bodily functions, both that we're aware of and many of which we're not aware of. And they span from the spinal cord, as I said, to the muscle nerves and internal organs. And they could be broadly divided into three main categories. Motor nerves, which control the muscle and movement. Sensory nerves, which convey sensation from the skin, joint, and internal organs. And autonomic nerves, which control involuntary functions such as breathing, heart rate, blood pressure, temperature, sexual function, etc., even bone growth. If you really concentrate, you can learn to control these functions, like increase or reduce your heart rate, but it's hard. Usually it's done automatically by the body, depending on to maintain an equilibrium. And this is just a diagram of the peripheral nerves. They emanate from the spinal cord. The motor nerves emanate from the anterior spinal cord. And the anterior horn where they're...
We can't hear you.
Use the microphone.
Got a long pointer. So the point of this slide is the peripheral nerves emanate from the spinal cord to go to muscles and skin. Sensory nerves emanate from the skin and backtrack to the spinal cord, posterior part. Motor nerves from the anterior spinal cord to the muscles. And there are areas within that track where the nerves travel together, and other tracks where they're separate. So occasionally lesions can affect one part of the tract or the other. So depending on the type or where the lesion is, you can have a pure motor neuropathy or a pure sensory neuropathy or a combination of sensory and motor neuropathy and autonomic neuropathy. And then when a patient presents with neuropathy, we first listen to the symptoms, trying to find out what they might be due to, where they're emanating for, which part of the nervous system. And then we try to confirm that suspicion on the neurological examination. So different symptoms have different abnormalities on examination that go along with that. And based on the combination of symptoms and signs, we can localize a lesion and try to develop a differential diagnosis. So, for example, people with motor symptoms, sometimes they're obvious, for example, weakness. Sometimes they're less obvious. For example, the earliest symptoms of weakness is really heaviness in the legs. And you don't think of heaviness as weakness, but it's an early manifestations. Or easy fatigability. People used to be able to walk 10 blocks, and now they're down to 5 or 2. that could, without being obviously weak, but they tire more easily. And also you can get muscle twitching, which is a symptom of motor neuropathy. The motor nerves are excitable and makes the muscle twitch. Very few other things can cause the muscles to twitch besides neuropathy. And then on the exam, obviously, we look for signs of weakness, and different physicians evaluate weakness in different ways. My boss at Columbia used to use 2 fingers to try to overcome strength. Another teacher who was very well regarded used to try to arm wrestle the patients to the floor. It's just a matter of individual style. And then there's some functional things you could test. For example, I may not be able to show weakness on muscle exam, but the patient might have difficulty getting up on the heels or toes or getting up from the floor, which is a more demanding function, which could be an early sign of weakness. And then sometimes atrophy of the muscles, like thinning of the muscles, could be a sign of motor neuropathy. And then also sometimes you could visibly see the muscle twitching, which correlates with the symptoms of twitching. And then in some types of neuropathy, the reflexes are absent, but in others they're present. So if they're absent, that might be helpful. If they're present, it doesn't really provide necessarily useful information. And the sensory symptoms also vary. They could be insensitivity to pain or temperature. For example, some people don't realize they have neuropathy until they've touched something hot and not feel it, or puncture the toe in a nail and not feel it, and they realize they have sensory loss, but they may not have any other symptoms of neuropathy. Sometimes they have spontaneous sensation, and the sensation of numbness is really a spontaneous sensation, because sometimes you just don't feel anything. So other typical symptoms are tingling, pins and needles. There could be quite bizarre. There could be burning sensations, hot and cold sensations, squeezing, itching. Unless you're familiar with these, you might think that they're not recognized, or think there's something emotionally wrong with the patient, because it's not something that you would expect. And sometimes patients have dysesthesia, which is an unpleasant sensation elicited by an ordinary stimuli. For example, sometimes people describe as if wearing a shirt irritates their skin, or they feel like they're sunburned, or touch feels electric, things of that sort. And so it's an altered sensation, really based on dysfunction of the peripheral nerves, and sometimes just incoordination. If you don't have a good sense of where your feet and hands are, you become uncoordinated, especially if you close your eyes. Sometimes in the shower, for example, you close your eyes, you could fall over because the eyes compensate for the lack of sensation in the feet. And then in terms of the exam or signs, we test patients for ability to sense vibration with a tuning fork or pin with a safety pin, or light touch, or temperature, such as something cold or something warm. It's interesting, once I assigned some of my students to look up where some of these earliest neurological tests came from. The neurological exam hasn't changed in 2 centuries. So people back when were very smart, or were not, really haven't gone very much further from where they were. But for example, I asked them to look up who invented the safety pin, and it turns out was the Greeks. They used fish hooks to clasp clothes, for example. So it goes way back. And then we test for coordination, asking the patients to walk a straight line, or with their eyes closed, etc., or touch their nose with their fingers, etc. And then autonomic symptoms and signs may be more difficult to detect. You have to look for them. For example, sometimes when you stand up, the body normally adjusts, the blood pressure goes up to compensate, but sometimes it doesn't. It could fall and people can get dizzy, and sometimes they describe dizziness, but sometimes it's just a lightheadedness or a heaviness around the shoulder, or gastrointestinal dysfunction. But the key is that it happens when you stand up from a sitting position, where there's a rapid change in autonomic tone. Sexual dysfunction is an early symptom. Incomplete bladder emptying, gastroparesis or bloating after eating, constipation alternating with diarrhea, intolerance to change in temperature. People, for example, can't sweat, they get overheated. On dry skin, it affects your hair and causes brittle nails, poor healing after a cut. Also, some people complain of chronic fatigue or brain fog, but we think that might be due to a lack of regulation of blood flow in the brain because of the neuropathy, because the nerves also control the blood flow and cause vasodilation, vasoconstriction. And then in terms of signs, we look for drop in blood pressure when people stand up, but something that's been, and that's called orthostatic hypotension. Something that's been recognized more recently is something called POTS, or Postural Tachycardia. When people stand up, sometimes their heart rate goes way up, over 100 or 120 sometimes, and not enough, since the strokes are rapid, not enough, and each volume is less, not enough blood gets into your brain, which has the same effect as lowering the blood pressure. And sometimes people have skin discoloration, turn bluish or whitish, or feel sweaty or clammy. That's because of autonomic dysregulation. So other things we do are nerve conduction studies. If you've ever had these, you're probably very aware that basically, since the nerve functions like wires, we could, I don't know if you remember from high school physics, you could stimulate a circuit and then watch the waveform in the oscilloscope. You can look at the waveforms, how fast they move down the wire, and whether they lose amplitude or energy. And the same thing can be done with nerves in the skin. It hurts a bit, but it's a useful test. It allows us to ascertain if there's neuropathy and a type of neuropathy, etc. And the EMG, which is the needle part, measures the muscle response to the electrical stimuli. And sometimes there has to be a certain threshold of damage before the neuropathy is picked up in these electrical studies. So in some patients where they have a milder neuropathy, the EMG may be normal, but we could do a skin biopsy, which is a punch 3mm biopsy, and looks at the nerves in the skin. And in peripheral neuropathy, they're often decreased in density, which helps us make the diagnosis. And then we test for autonomic dysfunction, response to a sweating stimuli, heart rate variability, something called a tilt table test, where people are tilted, and then, when they're tilted upside down or sideways, you should see a change in blood pressure or pulse. So these are all to confirm suspicion of autonomic dysfunction. Now, the EMG nerve conduction studies are particularly important. They identify the presence of neuropathy. They can distinguish between neuropathy as a cause for the symptoms and other potential causes, for example, ALS or motor neuron disease, things like myasthenia, neuromuscular junction diseases, or myopathy, which primarily affects the muscles. And also, it distinguishes between, if there is a neuropathy, whether the neuropathy is primarily demyelinating or affects the myelin sheath, or axonal, affecting the axon. The axon is like the core of a wire, like the copper core. The myelin sheath is like the insulation, and different conditions affect one part of the nerve or the other, and there are different treatments. So this just shows a peripheral nerve. You can see the myelin is the insulation, and when the disease affects the myelin sheath, the myelin unravels and exposes the core, the axon, and so subsequently it causes changes in conduction and in function. So it's particularly important to distinguish between whether the neuropathy is demyelinating or axonal. If it's demyelinating, there's a limited differential. It's either hereditary or autoimmune. The autoimmune conditions all have treatments. If it's axonal, there are many, many causes. And if no cause can be found, and we call it idiopathic, and there's no treatment aside from physical therapy and symptomatic treatment for the pain. But if it's demyelinating and all the other blood tests are normal, then the diagnosis is likely to be something called chronic inflammatory demyelinating neuropathy, and which is a treatable condition. So it's an important distinction whether the neuropathy is demyelinating or axonal. Sometimes if the electrical studies are inconclusive, we could do a nerve biopsy, which allows us to look at the nerve to see which part is affected. So this is just a diagram of peripheral nerve. In cross-section, you could see the dark areas, circles. Those are the myelin sheath which surround axon. In a demyelinating neuropathy, you could see some of the axons lose their myelin sheath. In axonal neuropathy, there's a dropout of both axons and myelin. And this is where we actually could tease out the nerve fibers, and you could see areas marked by D on the bottom, for example, where there's whole segments of nerve lack myelin sheaths. So again, this is just to emphasize the evaluation. So if neuropathy is suspected, we do EDX electrodiagnostic studies, and then it's differential as axonal or demyelinating. If the electrodiagnostic studies are normal, then we do a skin biopsy, and if that's abnormal, then we classify this as a small fiber axonal neuropathy. So under demyelinating neuropathy, if you test for known causes, you find a cause, by blood tests, you treat that. If you don't find a cause, by definition, the neuropathy is CIDP. It's a strange disease. It's defined by presence of demyelination and everything else being normal, and that's treated with steroids or gamma globulins. If it's an axonal neuropathy and the blood tests don't show a cause, then we call it idiopathic and there's no treatment. So there's a big difference between being told you have a treatable disease or CIDP or an untreatable disease, which is idiopathic axonal neuropathy. That's why you really have to be careful to do the electrical studies very, very diligently and with great care. So the other thing which the electrical studies help is, in some people with weakness, the differential comes down to neuropathy, motor neuropathy, which is a treatable disease, or ALS, or motor neuron disease, which is not treatable, degenerative condition. And the electrical studies help distinguish between those. Sometimes there are people with motor neuropathy have high levels of what's called anti-G1 ganglioside antibodies, which help distinguish between the two conditions. And in cases where the blood tests and the electrical studies are uncertain, you can also do a motor nerve biopsy, which help you make a diagnosis. So for example, this is a cross-section of a motor nerve biopsy, and you can see these clusters. So these are called regenerative clusters, and they're evidence of regrowth of axon after neuropathy or axonal damage. In ALS or motor neuron disease, the nerves don't regenerate, so you don't see that. So for example, if you look at the number of axonal clusters in motor neuron disease on the right, or in motor neuropathy on the left, there are a lot. You could see that could help distinguish between the two conditions. You see a lot more clusters on the left. So if the other tests are not definitive, then this motor nerve biopsy could help distinguish between the two conditions. And again, that's an important distinction. Neuropathy is treatable, motor neuron disease is not. Now, small fiber neuropathy, it turns out it's very common. About a third of all the patients we see here have small fiber neuropathy. Patients mostly complain of pain. And it could be really strange types of pain. It could be any part of the body. It could be in the arms or legs, face, back. It could come at any time of day or night. And until the past 10 years, all the tests were normal, and many of these people were told that there's something, it's psychological or emotional, we're sent to psychiatrists. But then we developed the skin biopsy test, which allows us to enumerate the small fibers. And many of these people have turned out to have small fiber neuropathy, and some of these have strange syndromes because, for example, it turns out that half the people with fibromyalgia actually have abnormal skin biopsies and really have small fiber neuropathy. Again, the difference is fibromyalgia is not treated, small fiber neuropathy is treated. Also, chronic Lyme, these are strange pain syndromes and autonomic symptoms, which people that used to have were treated for Lyme disease they were treated, the Lyme supposedly got better, but these symptoms persisted, and there's this huge debate, it's become political, as to whether they have chronic Lyme and need to be treated with antibiotics for the rest of their lives, or whether they have some other autoimmune disease, or whether it's on their head. And again, turns out it's a form of small fiber neuropathy, and it's leftover damage. It's not progressive, but it at least explains the symptoms and shows that they're real. So this is just an example of a skin biopsy with showing a small fiber neuropathy. On the left, you can see the small fibers traversing the skin. And on the right, you can see the skin is devoid of these fibers. So that's also a very useful test. And that's only done if the EMG nerve conduction studies are normal. If they're abnormal, then you don't need a skin biopsy to make a diagnosis. The skin biopsy doesn't really tell you what the cause is, just whether you have a neuropathy or not. And this, again, looking at sweat glands, the small fibers in sweat glands. On the left is a normal sweat gland. On the right, you can see there's a lot fewer fibers. So let's say we've established that the patient has neuropathy. We found that it's demyelinating or axonal. So then we narrow down the differential further. Again, if it's demyelinating, it's either immune-mediated hereditary or caused by certain drugs. For the immune-mediated, there are several types: chronic inflammatory demyelinating neuropathy, where all the blood tests are normal. There's something called multifocal motor neuropathy, and something else called MAG neuropathy, with antibodies to myelin-associated glycoprotein. There's something called Pohn's syndrome, which is associated with a bony myeloma. They have very high levels of something called VEGF and peripheral neuropathy. Sometimes the neuropathy is the presenting symptom, and then the further testing shows the myeloma. So patients are evaluated for these conditions. Axonal neuropathy, I would say in about 90% of patients with demyelinating neuropathy, or over 90%, we could identify the cause and treat it if it's not hereditary. Axonal neuropathies are more varied. There are many, many causes, and more of those are idiopathic, or we can't find the cause. And there's a huge list of causes, which I'll quickly go through. The most common cause is diabetes. Sometimes thyroid disease or kidney disease. Certain infections cause it: Lyme disease, hepatitis, HIV, leprosy. There are various autoimmune rheumatological syndrome, the most common, which causes neuropathy: Sjogren's syndrome, sarcoid. Celiac disease is a cause. There could be something called vasculitis, which is inflammation of the blood vessels. Most rheumatology patients, if you do a skin biopsy, if they have pain, if you do a skin biopsy, they have a small fiber neuropathy as a manifestation of the rheumatological condition. Some neuropathies associated with tumors, we call these paraneoplastic. There are various types. Some are drug-induced, most commonly chemotherapy for cancer. Certain antibiotics cause neuropathy, and statins, certain drugs like statins and colchicine can cause neuropathy, and others as well. Nitrous oxide is interesting. Nitrous oxide binds B12, so if you're B12 deficient, and you breathe nitrous oxide, it ties up your B12, and you get a sudden onset of severe neuropathy, and sometimes myelopathy, which is a spinal cord condition. Used to be an occupational hazard for dentists because they would relax by breathing nitrous oxide, which they have access to. But now it's more highly regulated, not as available. Still occasionally see somebody using nitrous oxide as recreational drug coming in with a neuropathy due to that. There are certain environmental toxins which cause it. The most common one is mercury. Turns out that mercury in seafood, where it's converted to organic mercury, is actually much more toxic than mercury, elemental mercury, which is found in mining. And I would say about 5 to 10% of the people that we see here for neuropathy, most commonly small fiber neuropathy, have highly elevated mercury levels in their blood from excessive eating of seafood, sushi, things like that. The only fish that doesn't have mercury is anchovies, but unfortunately it doesn't taste very good. So, and some people have seafood every day and they think it's healthy. Supposedly it's better than cholesterol and meat, etc. But it can overdo things. So I always joke around and tell them that when the Pope says you have to eat fish on Fridays, he means only Fridays. So again, everything in moderation. Certain nutritional deficiencies, like vitamins B12, B1, and B6 can cause neuropathy. And you may be eating a normal diet, but you're not absorbing it. So you just have to test the blood levels. But other supplements, for example, B6 can cause neuropathy if you take too much of it. And the normal daily requirement of B6 is about 2 milligrams, and some of these supplements have 100 milligrams. And I've had patients who take lots of supplements that take as much as 1,000 milligrams. It's shown in animal studies to cause the sensory nerves to die in people that can develop a painful sensory neuropathy. So, someplace else where that's important is I find that pregnant women, for example, frequently, if they come in with symptoms of neuropathy, there are many causes for neuropathy in pregnancy, most commonly the swelling with carpal tunnel syndrome, but sometimes their nutritional needs change, and sometimes they take supplements in high doses, which can cause toxicity. So I think the appropriate thing to do is, rather than just take or not take things, is just to measure the levels of these in the blood, and if you need to, take supplements. And then if you take supplements, measure the levels to make sure you're taking appropriate amounts. And then it gets into the issue of diagnosis. What do you call it? And there's so many different types and causes. So the sort of amalgamation of all these factors. So we call it based on the cause, the type of nerve fiber, the distribution, or of course whether it's acute or recent sudden onset or slow progressive or remitting and relapsing. So an example is idiopathic, progressive, large or small fiber axonal neuropathy. Or in diabetic neuropathy could be diabetic motor neuropathy, or sensory neuropathy, or small fiber neuropathy, etc. So what you call is really a mixture of all these elements. But idiopathic is interesting. If you look at the Latin root of idio, it's unique, but it's not really unique. A lot of people have it. I think we need to change the term. Some of my patients say it's a combination of idiotic and pathetic. And I can see why they're pissed off. Going on, so what do you do if the neuropathy progresses and no cause can be found? Sometimes people present with neuropathy and it's there, you can't find a cause, and it doesn't really get any worse. So the assumption is something happened in the past, damaged their nerves and left. Maybe it was inflammation, maybe some toxin, who knows. But that's okay. Then you don't necessarily have to do anything at that point. But sometimes it just keeps getting worse, and you don't want to miss a treatable cause. So there's such a things we would do in somebody whose neuropathy progresses if they're first diagnosed idiopathic is first repeat the electrical study. Sometimes if the neuropathy progresses, they would then show abnormalities which weren't detected early on, and that can happen. For example, we could detect demyelination if the neuropathy progresses, where wasn't detected earlier, and demyelinating neuropathy is treatable. If it's not demyelinating, it's not treatable. The default diagnosis is axonal if it's not demyelinating, but you have to meet certain threshold criteria. So repeating the electrical test is useful. Then if the patient hasn't been tested for hereditary neuropathies, even though there's no family history, it could be that the family history is vague or unreliable, or this could be a first generation. So we test for hereditary causes. These are just blood tests. Sometimes we look for an occult tumor. The best test for that is a PET scan. And then in about 20% of the cases, you can find a diagnosis based on a nerve and muscle biopsy, which we don't like to do unless the neuropathy is progressive and there's nothing else to offer, because it's an invasive procedure and sometimes causes lingering pain, but it's also very useful. If it's done by somebody who's expert in doing the biopsies, it's rare to have complications. So the sorts of things that we find in such patients where no cause could be found by other testing is something with non-systemic vasculitis, which is inflammation of the blood vessels only in the nerves, not in any other part of the body. You can see that inflamed blood vessel on the left. Sometimes you see deposits of something called amyloid. It's usually associated with abnormal immunoglobulin light chain in the blood, which is an abnormal protein, but sometimes it's in small concentrations in the blood, so you could miss it, but the biopsy would pick it up. Sometimes there's something called sarcoidosis, which are inflammatory granulomas, which can affect most frequently the lungs, but sometimes affects just the nervous system, and you can only identify it by nerve and muscle biopsy. And sometimes you could find, CIDP, which hasn't been picked up by the electrical studies, again because there's too much axonal damage, which masks the specific changes for demyelination. And then so all these conditions are treatable. Now in terms of treatment, again, we treat the underlying cause and we treat the symptoms. So for the underlying cause, if it's diabetes, the only thing which works for diabetes really is correcting the hyperglycemia. Diabetes causes many, many changes in the body. It changes metabolism, changes the blood vessels, changes the immune system, makes you more prone to infection, etc. And most medications for the neuropathy in diabetes targets one or the other of these and doesn't affect all those pathways. The only thing which affects all the pathways is controlling the blood glucose levels. And some patients with diabetes have bad diabetes but don't have neuropathy, and some people with diabetes have mild diabetes and bad neuropathy. What happens, many endocrinologists look at the blood levels, they don't look at the other manifestations of diabetes, and they're happy as long as it's below a certain level. But I always tell patients, if you have diabetes and neuropathy, you have to be more careful about your blood sugar levels, and you have to aim for a lower level than somebody who doesn't have diabetes or other complications. And sometimes you have to explain that to the endocrinologists. For the autoimmune neuropathies, prednisone is a strong anti-inflammatory agent, but lots of side effects long term, so we don't like to use it. Intravenous gamma globulins works for some autoimmune neuropathies, and in other patients are treated with rituximab, which is anti-lymphocyte B-cell reagent, or chemotherapy, and there's a long list of chemotherapy agents we use for things like vasculitis or other immunological syndromes. If it's a toxic neuropathy, you eliminate the toxin. Same thing with nutritional neuropathies, you correct it. Treat the infection if there is one, or treat the tumor if there is one. One thing to keep in mind, if we treat the cause of the neuropathy, the neuropathy stops progressing and the nerves have a chance to heal. There's nothing that we have, however, at the present which really hastens healing. All we do is stop the damage, and then it's up to the body to repair. And depending what the cause of the neuropathy and severity, some patients get all better or better enough so that they don't feel abnormal, or they might be left with some symptoms. and then you would treat the symptoms. The nerves regenerate imperfectly. It's a complex structure. It involves, target organs and myelin sheath and axons and so on. So even when it heals, the architecture is never quite the same, so people might be left with symptoms. And people have to learn with a certain level of discomfort sometimes. And you can certainly treat the pain, but if you try to treat to a point where you don't feel any pain at all, often you end up with toxic level of medication. So you have to kind of find a compromise and a level where you're not affected by the drugs themselves adversely, and where the pain is controlled. And there are many treatments for the pain, both by medications and with intervention. Invasive procedures. Certainly, regardless of where you start, exercise or physical therapy can make you 10% stronger and function better. It's frustrating sometimes, although it's nice. Patients come in, they're getting a lot better, and the neuropathy was treated, and the nerves are healing, and we're kind of proud of being able to treat it properly. But they give all the credit to the physical therapist. But you could see, obviously, you could see the improvement, measure it, and it's an encouraging experience. So physical therapy is always helpful. And then, there are many medications for the pain. The most common ones are gabapentin or Neurontin or Lyrica or Cymbalta, but there are many others that could be tried alone or in combination. More recently, it turns out marijuana is very helpful to patients that where the other therapies don't work. It's an interesting drug. It has a lot of medicinal properties. But there hasn't been an awful lot of research in it because it's been highly restricted, so it was very difficult to get permission to work with it. But I think it's getting easier, and it's certainly worth trying in anyone that is not responding to the other medication. Also helps you relax and sleep at night at the same time. And the doses they use are not really hallucinogenic. They're just enough to control the pain without causing a high. And then with autonomic symptoms, again, you treat if there's loss of, low blood pressure, you try to raise the blood pressure with fluids and medications, or if there's heart rate's too high, then you try to slow it down with medications. This is in addition to treating the underlying cause. This is just a couple of slides on some research we've been doing. So work on inflammatory neuropathies, and they're really the foot soldiers in the immune system is the macrophage. It's involved in, it's in all the organs, and actually can directly damage the cells directly, and also by mediating antibody damage. And we found that the macrophage has this receptor on the surface of it called CD204, which is a protein receptor. And we made antibodies against it, which blocks the receptor, and tested in animals with Guillain-Barré syndrome or inflammatory neuropathy. So this is a disease score of severity of the neuropathy, and you can see in blue, neuropathy starts around day 10, peaks day 15, and then kind of improves spontaneously. And then if we treat them with this antibody against this macrophage receptor, the neuropathy is attenuated. If you could see that green line on the bottom, so that's the clinical score.
Wow.
After getting the antibody. And if you look at the nerves from these rats, on the left you can see a lot of inflammatory cells in the diseased animals, and in the middle panel is the treated animals where it prevents inflammation, and the right is just a control panel. So we're still working on it. Hopefully, I always think of doing research as playing baseball. You have a, you get a pitch, and you hit it, and sometimes you get to first base, and then you can make it to second base, and sometimes as the research progresses, you might find out you hit a wall and you strike out and you can proceed, but sometimes you make it all around the bases and get a home run and actually develop a drug which helps a lot of people. So anyway, questions? Yeah. Yes.
I have two. Seafood.